Thank you for your kind invitation, Stephen, Catherine, and Monica. Today, I will talk to you about a very important question. Could metabolomics assist disease management in critically ill COVID-19 patients? So hopefully we'll try to focus on patients who are at highest risk of, unfortunately, death. So as you know, COVID remains a major threat worldwide, endangering lives of millions around the globe. 20% of COVID-19 patients exhibit respiratory distress that necessitates invasive mechanical ventilation or intubation. Among these, around 30% unfortunately die. So at times of crisis, intensivists need to predict the duration of ICU stay and IMV duration for better utilization of the ICU resources. So far, the accuracy of the early clinical prediction of ICU and IMV duration remains limited. So previous studies have shown that have compared actually metabolic profile of healthy versus COVID-19 patients, but most of these studies use measurements that were used at when the phenotypes were acquired, so they could hardly be predictive. Therefore, there is a need for predictive biomarkers which are measured on admission. So our hypothesis that COVID-19 triggers detectable metabolic alterations in the sera of intubated patients admitted to ICU, which can be used to differentiate patients who are likely to recover from those who are likely to longer stay at ICU. And for that, we aimed to perform target metabolomics in the sera of critically ill COVID-19 patients in the ICU on admission and a week later, and also to identify predictive biomarkers of ICU and mechanical ventilation duration in critically ill COVID-19 patients. So our cohort was 39 participants, 37 males and 2 females, average age 48 years old, average BMI 28, days of intubation on average 9 days, plus minus 7. Days at ICU were average 17, however, the median was 14 days. And this is why we considered anyone who stayed less than 14 days as a short stay, and anyone who stayed more than 14 days as a long stay. Of course, they suffered from various comorbidities, type 2 diabetes, hypertension, coronary artery disease. On day 1, on admission, we measured clinical traits. We carried out metabolomics from the sera, and we characterized how many intubated, extubated, how many are at ICU, how many on ECMO, and how many died. We did the same on day 7, but on day 14, 21, and 60, we only looked at the outcome. So the phenotype, I just want to draw your attention to the phenotype. We looked at 2 different phenotypes, the continuous phenotypes, where the days at ICU and days under mechanical ventilation, and the categorical phenotypes where the short versus long stay, so the less or more than 14 days at ICU, and the status of whether they're on ECMO or not. And we used metabolomics was performed using the Biocrates MXP Quant 500 kits. So initially, we compared changes in clinical traits between day 1 and day 7 at ICU, and we saw that the arterial pH became more alkaline, although the lactate actually became higher, so became more acidic. The triglycerides and liver function enzymes all worsened with longer stay at ICU. Bicarbonate became higher, perhaps explaining why the arterial pH became more alkaline. And fibrinogen and CRP were both decreased with stay because of most likely because of the medication. Now, when we compare the differences in clinical traits between short stay and long stay, what we saw is that the creatine got much higher, as well as the total bilirubin, which is basically explaining the kidney failure and liver failure. Apache score was actually the only kind of significant difference between the 2 categories, the short stay and the long stay. So the Apache score is kind of gold standard measure used to assess the severity of disease and the risk of death of an ICU patient within the first 24 hours of admission. And it's kind of complex calculation, which takes into account 14 different measures, age, history of severe organ insufficiency, renal failure, temperature, coma, blood pressure, etc. So this is what people usually use, and we use it as kind of our reference when we compared our predictive models. Okay, so the first model is the predictive metabolic biomarkers of length of stay at ICU based on day one measurement. So in this model, we carried out orthogonal partial least square discriminant analysis, which showed very clear separation between the long stay and the short stay. So the discriminant component explained up to 86% of the variation in the length of stay. Now, we divided our cohort into training set and predictive set. So the training set was n equals 17, and we carried out volcano plot. And here you can see very clearly some metabolites that were upregulated with a longer stay, sort of would change with longer stay. And here we carried out a predictive model based on GLM nets. And this one basically showed us that there is a significant difference between the long stay and short stay based on two explanatory metabolites, which are hypoxanthine and betaine. Now, we did a cross-validation to looking at predictive model of length of stay based on day one measurement in the predictive set, in the other parts, the 16 patients. And based on hypoxanthine and betaine, the model is still very, very predictive. And ROC analysis and the area under curve is 92%. So it was actually much more superior than the ROC analysis that was performed using the Apache score, the one that we described as the gold standard. This model is superior to Apache. Now, we tried to do independent validation in a cohort that was published in the Cell by a Chinese group, where basically they looked at 28 healthy, 25 non-COVID, 25 non-severe, and 28 severe. And our two metabolites explained the severity of the disease significantly. So our model is also predictive of disease severity. We carried out our own independent validation. So this is now another cohort that was collected at a totally different time. 158 participants. Age were slightly older than the first cohort. BMI is similar with comorbidities. And we found also that hypoxanthine and betaine-based model could predict disease severity also significantly, as we saw in the Chinese group. So that was kind of independent validation. Now, moving to the second phenotype, which is the days of intubation or IMV days. Also, we did this model based on measurements on day one and on day 7. So based on day 1, we carried out, remember, this is now continuous variable. So we did OPLS, and the OPLS explained 86% of the variation in the length of IMV. And here in the volcano plot, we identified metabolites that are responsible for long or short IMV. And here you can see some that were upregulated in red and some that are downregulated in blue. We carried out GLMNet as well. And here we can find that our model had a correlation coefficient of 85%. And it was based on 4 metabolites: creatinine, D-dimer, 3-methylhistidine, and lysophosphatidylcholine C24. So then we did cross-validation in the predictive set in the 16, and the model was still predictive. So here the correlation coefficient was 76%. Here you can see, looking at what happens to these metabolites with the intubation days, 2 of them, creatine and D-dimer, were going up. Sorry, creatinine and D-dimer were going up, whereas 3-methylhistidine and the phosphatidylcholine were going down. Compared to Apache score, our model was superior, could explain 76%. We tried then to do correlation between the observed ICU and the predicted ICU based on our model, and our model was still predictive. There was a positive correlation between the observed ICU days and predicted based on this model. But this model was not convincing enough. So we carried out a predictive model based on day 7 measurements. And this model, the OPLS discriminant component, actually could explain now 94%. So it's already showing us a better predictive ability compared to the model based on day 1. And here in the volcano plot, you can see metabolites that were kind of responsible for this differentiation, IMV's duration. Here you can see that they are different from metabolites that were shown from day 1. Canurine kind of appears here, top metabolite. And here, based on GLMNet, we carried out a predictive model and the correlation coefficient now is 97%, and it's based on 5 metabolites: carnaurin, 3-methylhistidine, ornithine, phosphocrystal sulfate, and sphingomyelin C24-1. So then we did the cross validation in the predictive set, and here the model is still very predictive. You can see correlation coefficient still 94% in the predictive set. So here we can see what happens to the metabolites. So we have 2 that go up, carnaurin and phosphocrystal sulfate, and 3 that go down, ornithine, 3-methylhistidine, and sphingomyelin C24-1. Again, we did a cross independent validation in the Chinese cohort, and again, our metabolites could predict disease severity. And when we did the correlation between observed ICU days and predicted ICU days based on these metabolites, we get now a better correlation coefficient. So our model based on day 7 is superior to model based on day 1. Now, finally, we looked at predictive biomarkers of ECMO status, so whether patients were on ECMO or not. Unfortunately, we could not, because of the small number of ECMO patients, we only had 5. We could not divide it, obviously, into training and predictive. But you can see 2 factors, not metabolites, 2 clinical traits: arterial pH and white blood cell count. And you can see that they showed kind of a significant difference between whether you're in ECMO or not. And obviously, this needs to be repeated in a larger cohort. So now, just to discuss very briefly what this means. So predictors of length of stay, hypoxanthine and betaine, both were reduced with a longer stay. So hypoxanthine has been already associated previously with malnutrition at ICU. Betaine the low levels have been associated with various metabolic diseases such as vitamin D deficiency, lipid disorders, and type 2 diabetes. It's the first time they've been associated, as far as we know, with ICU outcome, but they have been already shown to be associated with other kind of comorbidities. Predictors of IMV based on day 1 were creatinine D-dimer. So creatinine is usually indicator of kidney function, kidney failure. A D-dimer is indicator of increased coagulation. So they were both going up with IMV duration. Whereas the 3-methylhistidine and the lyso-PC C24 were basically both described as signal molecules modulate inflammation. So we are still looking into their function. And the predictors of IMV based on day 7, carnaurin, we heard a lot from Julie this morning, earlier. So the metabolite of the amino acid tryptophan used in production of niacin. It has been now lots of reports showing its role as a regulator of immunity and inflammation. And also phosphocrystal sulfate is a uremic toxin, also has been associated previously with kidney disease. Again, 3-methylhistidine, we see it in both models. As we said, this signal molecule can modulate inflammation. Ornithine and sphingomyelin, they both have been associated with various outcomes at kind of different diseases, but we could not really find direct link with ICU. And predictors of ECMO, arterial blood pH. So it's an indicator, obviously, of acidosis. And the white blood cell count is, reflects the hyperimmune response, which could indicate overall worsening of the clinical state. So finally, to conclude, we have shown, so to answer the question that we raised initially, we have shown that the reliable prediction of IMV and ICU duration is actually possible based on measurements taken on day 1. Therefore, it might be possible to discriminate patients who are generally about to have short versus long stay on admission. In general, with the identified predictive biomarkers were associated with medical complications to COVID-19, such as inflammation, coagulation, kidney injury. The proposed models outperform the predictive ability of Apache score, which is the gold standard, which is usually predictive of fatality and accepted as predictor of disease severity. Finally, we acknowledge that it is limited by number, but now we have conducted the larger study, and we're currently replicating all these different models. Finally, I would like to acknowledge my colleagues at Qatar University, at Hamad Medical Corporation, Hamad bin Khalifa University, and ITEM for their kind support and collaboration. And thank you very much for your attention. I'll take your questions.